Queen Anne's County, Maryland, sits on the eastern shore of the Chesapeake Bay. It's just an hour east of Washington, D.C., but it might as well be a world away. It's a place of rolling farmland, winding creeks, and quiet towns where the pace is slower, but the sense of community runs deep. This is a rural county. About 54,000 people spread across more than 500 square miles. And while that rural beauty is part of what makes Queen Anne's County special, it also comes with very real rural challenges. For many residents, accessing healthcare means driving an hour or more to the nearest provider. Public transit is limited, primary care providers are in short supply, and unlike urban centers, we don't have hospitals or bustling health clinics on every corner. That's the reality that the Mobile Integrated Community Health Program was built to address. We aren't a large program with vast resources or numerous teams in the field. We are a small, scrappy team. A community nurse, a paramedic, and a telehealth-connected pharmacist. Our mission is simple: to bridge the gap between people and the care they need, especially those falling through the cracks of the healthcare system. These are patients with multiple chronic conditions who are often isolated, managing complex medication regimens, and struggling to navigate a fragmented healthcare system. Every visit starts the same way. We step inside and begin to piece the story together. We start with the basics and review their medical history. We do a physical exam and check the home for safety risks, but we also ask about how they live, what they eat, and how much they understand about the conditions they've been told they have. We screen for prediabetes using the CDC's tool, but also for fall risk and signs of substance abuse, and whether they can make sense of all the medical jargon they've heard, visit after visit, discharge after discharge. And then we get to work, almost like detectives, trying to figure out what's really going on underneath all those repeat 911 calls and hospital visits. Maybe it's the falls, happening more and more often because they have a maze of clutter and layers of throw rugs and aren't aware that they should probably be using a rollator or a walker. Maybe it's the insulin they skipped last week, not because they didn't want to take it, but because the last of their money for the month went towards the electric bill. Maybe it's the stack of unopened mail on the kitchen table, appointment reminders, prescription refills, because their glasses are broken, and no one realized they haven't been able to read their mail in weeks. The team works to solve problems as they find them, right then and there. And when it's something they can't fix alone, they don't quit. They connect the patient with local resources, community programs, faith-based groups, and support networks. Whatever it takes to build a bridge from instability to something steady, sustainable, and connected. The backbone of our program, the piece that takes everything we do to the next level, is our real-time telehealth connection with a hospital-based pharmacist. Melanie joins every visit virtually. While we're with the patient, she's logged into Epic, comparing what's prescribed with what's actually in the home. She provides medication reconciliation, counseling, and real-time coordination with doctors and pharmacies. In nearly every home, and this is no exaggeration, she uncovers a problem. It could be missing prescriptions, duplicate medications, or even dangerous medication combinations. And she doesn't wait. She doesn't put a note in the patient's electronic health record and move on to the next, hoping someone else will follow up somewhere down the line. She acts right then, calling providers, updating the pharmacy, looping in case management, all while we're still in the living room and the patient is hearing the plan come together in real time. Most communication between providers and care teams happens through chart notes, voicemails, and email inboxes, but this happens in real time. It's quick, it's clear, it's connected, and it means problems get solved before we've even packed up our bags to leave. To give you a snapshot of our target population, most of our patients are over the age of 65, with an average of 10 medications and 6 chronic conditions. Nearly half live alone. We stay with them through follow-ups, coaching, and coordination until things stabilize. But the snapshots don't always capture the whole story. To understand what this program looks like in practice, you have to step through the front door with us. You have to sit on the edge of a worn recliner and notice the cold meals left untouched. the medication bottles jumbled in old cookie tin, the faint, baked-in smell of meals left too long on the burner. You have to see the walker that's out of reach and covered in laundry, or the throwaway rugs curled at the edges. The follow-up instructions still folded inside the hospital discharge folder, untouched, on the kitchen table. These are the things no one sees from a hospital bed or an exam room, but in the home, they're right there in front of you. Let me tell you about a woman we visited not long ago. We were asked to join Adult Protective Services for a wellness check on an older woman who was reportedly being neglected. A member of her church had raised concerns. When we arrived, the grandson's girlfriend met us at the door. It was a multi-generational home, crowded and cluttered. Upstairs, the bedroom was dim, dusty, disorganized, and had a heavy scent of stale air. She lay in bed surrounded by half-eaten toast and old microwave dinners. Medication bottles were scattered across the tops of her nightstands and her dresser. She mentioned she'd been wearing the same socks for weeks and asked if we could help her change them. When we gently removed them, the fabric had started to adhere to her skin. She couldn't remember the last time she'd had a proper bath. The room was too cluttered for her to use her rollator or her wheelchair, and despite having a wheelchair-accessible bathroom, she was using adult diapers and a bedside commode, because it was easier to do that than to try to navigate the obstacles that were in her room. The team did their assessments and started the telehealth visit with Melanie. We discovered several prescriptions: blood pressure meds, pain relievers, anti-inflammatories. But she didn't know when she'd last taken any of them. 2 of the medications were found to be dangerous combinations when taken together, and over 50 gabapentin pills were missing from her newly filled prescription bottle. She suspected her grandchildren were taking them while she was sleeping and selling them. Gabapentin, when taken with opioids, can significantly enhance the sense of euphoria. We immediately began to clean and organize the clutter to make a path wide enough for her wheelchair so that she could use her bathroom again. The bathroom itself had become a storage space, filled with boxes, piles of clothes, and various odds and ends. We cleared it with help from the family. We secured the remaining gabapentin in a zippered pouch and put it in the inside pocket of her bedroll. That way it's still accessible to her, but it's less vulnerable to theft. And while we did that, Melody was already on the phone with the patient's primary care provider. She got a next day appointment, updated her med list, and contacted a home health agency. Since the patient can't make it down the steps without a great deal of assistance, we discussed moving her to a downstairs room, closer to the kitchen. But she didn't want to leave. Her late son had painted that room for her, and to her, it wasn't just any room. It was a connection to him. So we made it work. With support from our local area agency on aging, we got her a mini fridge and a microwave so she didn't have to rely on her grandchildren to bring her meals. At her 6-month follow-up, she was thriving. But not every case is about neglect. Sometimes it's about what's been missed. We visited a man who had been in and out of the hospital for months. No one could figure out why he wasn't improving, despite constant medication adjustments from his doctors. The care team referred him to us to investigate. During the visit, we asked him to hand us one of his medication bottles. He stared at them, silent, turning them over in his hands. Finally, the nurse asked gently, "Can you read these?" He shook his head. "No," he said quietly. "I never really learned to read. I know a few words, but I don't know what any of these say." We asked if anyone knew, if his doctor knew or his care team. He looked at the floor and shook his head. "Just my late wife and an old boss I had a long time ago." He'd been guessing for years. He wasn't non-compliant, he was illiterate and embarrassed. So he nodded through every appointment, every discharge summary, never saying a word. That moment changed everything. Melanie and the team began to brainstorm. He said he couldn't use his CPAP because he didn't remember the steps and couldn't read the instructions. So Melanie walked him through it, step by step, and made him demonstrate it for her again and again until he got it right. He had a stash of Tupperware containers with different colored lids. Melanie asked if he had a wall clock, not a digital one, but one with an hour and minute hand. And he did. So we took it down and pulled out our colored markers. We colored the space between the 7 and the 8 yellow and drew a coffee cup to signify the morning. We colored the space between the 12 and 1 in red and drew a sandwich to signify lunchtime. We colored the space between the 5 and 6 green and drew a plate with a knife and fork to signify dinner time. And we colored the space between the 8 and 9 blue and drew a crescent moon to signify bedtime. Each time block matched a container with that color lid. Inside each container was 7 sandwich baggies, one for each day of the week. If it is morning time and the hour hand moves into the yellow part and you see the coffee cup, you open the yellow container, take that day's baggie, and take your meds. It was simple and visual. No reading, just matching color to time. It wasn't perfect, but it was tailored just for him, and it worked. Someone from his church visits every Sunday to refill the containers for the upcoming week. That was 2 years ago. He hasn't had a single 911 call or a hospital visit since. This isn't flashy healthcare. It's not what you see in glossy hospital brochures. It's slow. It's personal. It's a conversation at the kitchen table, a phone call made in the moment, a fresh pair of socks, a safe path to the bathroom, a reason to believe that care can actually reach you right where you are. Queen Anne's County may be just an hour from D.C., but the gap in access, in equity, can feel like a lifetime. What we're doing is closing that gap, one home, one patient, one visit at a time, because sometimes all it takes to change a life is stepping through the front door.